Good afternoon, everybody. I'm very happy to be here. I'm going to begin with a brief description of the Israeli healthcare system, because I think it's an important context. I think that you will all see as I talk some of the similarities and differences between Israel and Estonia, because there are a lot of similarities, and you will see them as we go through this. Basically, Israel has the Israeli healthcare system is a universal, compulsory, statutory health insurance for all citizens. They are all required to be covered. It's financed by both earmarked and general taxation, and the coverage is provided by, instead of one national health insurance fund, by 4 competing nationwide health plans. Every citizen must join a health plan, but they're free to choose and move from one to the other about 6 times a year. The public and private providers of services, including physicians, hospitals, pharmacies, and other healthcare professionals. And the health plans are obligated by law to provide a legally defined public basket of services to all of their members. Now, one of the differences, I think, perhaps, between the Israeli system and other basically European Bismarckian systems, and I think perhaps also Estonia, is that the health plans are considered healthcare managers for their members and are also providers of services. They're not only insurers, but they also have an obligation, a legal obligation, to make sure that the services are provided. And so they either do it by providing services themselves using employed staff, or through contracting with independent private and public clinicians and providers. And it differs, the balance between that differs among the different health plans. Both primary care doctors and specialists work in community clinics, either solo or group practices, as opposed to, for example, last time I showed you Scotland. In Scotland, specialists are usually in the outpatient departments of hospitals, but this is not true in Israel. In Israel, they similar to Germany, and I think even Belgium, they work in community clinics. The GP is not a gatekeeper, which means patients can freely access other specialists, with the exception of some subspecialties that require a GP referral. And this policy is different among the health plans, but there are, like a neurosurgeon, for example, needs the referral. All of the health plans have contracts with all of the public hospitals, and payment to the hospital by the health plan requires health plan authorization. So if it's an elective admission, then it's required prior to the admission. If it's an emergency admission, then it's done after the fact. Another thing that I think is very kind of unique about Israel is that it has a huge amount of complementary health insurance. The majority of it is actually provided by the health plans, but also by private insurers, and it's very widespread. I mean, a huge proportion of the population, I think something like 80%, has some form of complementary health insurance, which enables them to get things that are above and beyond the public basket of services. Now, the eHealth system, in a sense, reflects to a large degree, the healthcare system. The digital health system in Israel is really a very decentralized system. So each health plan and hospital has its own eHealth system with data sharing of EMR data across systems. E-prescription, we have e-prescription, but it's done via the EMR. And in the health plans, the prescriptions are transmitted to the patient via the patient portal. There is a national health information exchange for sharing EMR data across organizations. And also we have very well-developed patient portals, which provide patients with access to medical data as well as virtual visits. And these are predominantly operated by the health plans. There's mobile access to the EHR for both clinicians and citizens. So, for example, the patient portal in, I think all of the health plans can be also accessed not only on a computer, like a desktop, but also by iPad or by mobile phone. Telemedicine is fairly well developed in Israel. for diagnosis as well as treatment in all of the health plans and in the hospitals. And of course, because Israel was a very early starter in this field of eHealth, there is a lot of work now being done in big data analysis, risk stratification, and there are registries at both the health plan and national level. One thing I think where we have a red mark against us is that there's still limited data sharing with social services. And this is basically from a high level architecture point of view, what the overall system looks like. You have the National Health Information Exchange network. It basically connects to a local health information exchange at each health plan, as well as each hospital. And therefore, basically, the health plans and the hospitals kind of populate the local health information exchange with data, with data from their EMRs and other aspects of their healthcare systems. So you can see that actually the overall architecture reflects the decentralized nature of the system. So I think one of the things that is unique in it is a function of the fact that Israel began this journey so early, is that all physicians and healthcare practitioners in Israel use EMRs, either of their health plan or their hospital. And the contract with the vendor is not done by the individual physician or clinician, but the contract with the vendor is either with the health plan or the hospital, and not with the individual practitioners. So for example, we don't have 6 different vendors working with GPs or doctors in the community. The health plan has their vendor, and all of the doctors working with that health plan are using the same EMR.
Yeah, thank you, Heil. It's just for the sake of following the flow of your explanation. In the previous slide, you mentioned e-prescription. Does it mean that you do not have any national server in Israel to collect all the prescriptions which are sent to a server? So would it be then only point to point, or is it also a CC prescription? Of course, also is it also open to any pharmacy who can collect that prescription?
Okay, so first of all, it's not a national, there's not a national server. Essentially, e-prescription is done by the health plans predominantly, even more than the hospitals. And because there's very little movement between health plans, it's something like 1 to 2% a year. So basically, all of the prescriptions for that patient, whether they come from the hospital or they come from a clinician, are all in one central server. And that pretty much encompasses for those patients all of his prescriptions. And the pharmacies, basically all of the health plans have contracts with all of the pharmacies. So the pharmacies are a part of that. And they actually have an interface with the systems of each of the health plans, so that when a patient comes to the pharmacy, for example, we have magnetic membership cards. Basically, all that has to happen is the pharmacy swipes the card and the patient's prescription comes up on the screen and he dispenses. So it's also a completely paperless process. But it's at the health plan level. There is not a national server. But it doesn't make any difference, because it doesn't matter where the patient is, all of the pharmacies can access. So does that answer your question, Luke?
Yeah, thank you for the clarification, Rahel.
Okay. Okay, so the EMR in the health plan is a central EMR, which means that every transaction between the health plan and the citizen is documented and transparent to all of the doctors caring for the patient. And of course, to other healthcare professionals as well, although not everybody can see everything. In other words, the family physician, for example, can see the whole record. Nurses see not only part of the record, and there's a set of basically authorizations depending on the healthcare professional role in taking care of the patient. Now, also the EMRs in the hospital are also central EMRs, and all of the public hospitals for and this is almost coincidental, are working with the same vendor, even though each hospital has done some unique developments in their EMR in accordance with their needs. Private hospitals also use that same vendor, although not exclusively. Some of them also have contracts with other vendors. But all of the hospitals, both public and private, and the health plans exchange information using the National Health Information Exchange, and they have all configured their data according to the standards and definitions established by the Ministry of Health for this purpose. So as I mentioned before, very briefly, all of the health plans have member portals that not only enable access to the patient's EMR information, but support virtual care, including e-prescriptions, referrals, messaging between clinicians and patients, making appointments, both face-to-face and remote. And by the way, patients, there is a legislation, the Patients' Right Act of 1996, which requires that giving the patient access to his medical information. Hospitals increasingly also have patient portals that support appointments and provide access to patient information such as test results and visit summaries. And the Ministry of Health has a citizen portal, which is informational and obviously has become increasingly important during the COVID pandemic for providing information, instructions, and tracking patients and tracking all patients vaccinated and providing green passports. Now, and I'm only mentioning this because somehow I think in one of the interviews I participated in, we talked about this from an Estonia point of view. But the Ministry of Health receives regular computerized reports from the health plans and the hospitals on a regular basis, and they actually even have a system that has been agreed upon where they monitor the activity of both the health plans and the hospitals, and certain agreed upon quality indicators. So, for example, all of the health plans provide data that enables the Ministry of Health to see to what extent, what proportion of the women who are eligible to get mammograms got mammograms in terms of breast cancer screening and other similar kinds of informations. And basically, this information is also public. In other words, theoretically, if they're interested in it, the citizens can go onto the Ministry of Health website and actually compare between the health plans and between the hospitals against these indicators. The Israel Center for Disease Control also receives data daily from the health plans to track potential outbreaks of infectious diseases. And they also manage a large number of national disease registries. The ministry is responsible for licensing and certifying all clinicians and healthcare practitioners and manages these databases. And the ministry now is, and I'll talk about this a little bit more later, is now moving rapidly into the era of big data because they have access to at least aggregate data on the population collected by the health plans and the hospitals. And they are beginning to really actively foster research and R&D in partnership with health providers and industry in this area. So I've already said this, I'm not going to repeat it again in detail. In terms of data sharing and access, what we've said, and it's very clear, is that if the health plan level clinicians have access to the central EMR, likewise in hospitals, and they all have access to cross-organizational data through the National Health Information Exchange. One of the things that I think we've seen over the past years is that patients have an ever-expanding access to their EMR data through their web portal or through their mobile. And now that's one of the things, for example, that was not included in the past was text information, which is now, they're now getting access also to text. But right now they can see their visit summaries, they can see all their medications that they have been prescribed and that they have purchased. They see all their test results, they get reminders for screening, vaccinations, and also personal recommendations based upon their age and past history. And as Luke has already asked, e-prescribing is basically done is the responsibility of the health plans. It's supported on the portal and it's completely automated. with electronic physician signatures and online access for doctors, patients, and pharmacies. As far as people, as training, Israel has a fairly high degree, I think, of digital literacy in general, not everywhere. And in a minute, I'll talk about places where it needs to be improved. But Israel's basically been running their eHealth system since about 1993. So that's a long time, and people have become very, very accustomed to working with the patient portal and doing things digitally, so that I think in a way it's unusual compared to some other countries, but I think there's a high degree of digital literacy among the population. But health plans and hospitals have structured courses as well as online support for all clinicians, healthcare professionals, and administrative staff. And they also provide instruction and online support for their members in using patient portals and other digital systems. And there are populations, by the way, that for many reasons do not have computers, very small, but nonetheless. And so they also have kiosks for populations that do not, at the branches, for populations that do not have computer access. Doctors and healthcare professionals strongly encourage their patients to use the health plan digital system. So if a patient wants to, for example, renew his prescriptions, his doctor basically encourages him to do that online and to use the system. And the reason he does that is because it's very convenient for the doctor, because all of the requests that the patient makes of his doctor via the portal go directly to the doctor's electronic medical record. So he doesn't have to go into a separate system to deal with it. It just comes right to where he is normally and regularly working. So it's very convenient for him. There is a national digital program by the government that's working in the area of digital literacy, focusing on the population from basically the periphery, both geographically and socially. And there's another organization called the Israel Internet Association, which has also been working to reduce the digital divide among communities, including elderly, children at risk, and the Arab Society. And they've been doing this for the last 21 years, and they've made a great deal of headway. When we look at the eHealth organizational structure, and I actually am doing a little bit of history here to sort of give you a context, it's basically the organizational structure of the eHealth system in Israel has been largely determined by its evolution. The eHealth system in Israel was very clearly health plan driven. The health plans were the ones who started to computerize their system early on, and there were already organization-wide electronic medical records in all health plans by 1995. There was a nationwide health plan teleradiology system by 1997, and the patient portals all began to be developed in the early 2000s. So, this was all done by the initiation of the health plans. So in the health plans, for example, and not by the Ministry of Health, because at the time that the health plans were implementing electronic medical records, health IT was not really a priority of the Ministry of Health. The Ministry of Health at that time was very focused on driving the reform of the healthcare system that led to the National Health Insurance Law of 1995, managing the ministry-owned acute care hospital system, and the ministry, by the way, owns and operates the majority of acute care hospital beds. So that was a big focus for them. They also have a strong prevention program, and so they were very focused on making sure that the population was vaccinated and providing maternity and child health care. Of course, they do licensing and certification and are responsible for regulation of the system. So prior to the implementation of the National Health Insurance Law in 1995, the health plans were completely autonomous organizations, highly competitive and accountable primarily to their board of directors. So the decision to develop and implement organization-wide electronic medical records, for example, they didn't have to go get permission from the Ministry of Health to do this. All they had to do was to make that decision, and they then had to make sure that their databases were registered with the National Database Authority. I think another important thing to note, which I think is very different from the situation in Estonia, is that all of the health plans began first with their GPs. And that sort of formed the bottom of the base of the pyramid in terms of the electronic medical record. They started first with the GPs, and then gradually extended it to all specialists in the community. And this, because we were so early, and we actually only had one vendor that had an electronic medical record in Hebrew. And it was sort of an embryonic record. Basically, the EMR were developed collaboratively with the doctors to support their workflow and provide additional value to them. And so this very much characterizes the EMRs of the health plans. In 1998, the ministry initiated the really first hospital-wide system, the NAMIR system, which was a computerized admission, transfer, and discharge system for all of their hospitals. And Clalit, which is the largest health plan, also owns hospitals, and it developed its own system for its own hospitals. So essentially, this basic structure has continued. And the health plans continue to develop and expand their EMRs, making them more sophisticated. Very early on, they started to introduce clinical decision support systems, which have become increasingly sophisticated over time. And basically, it's a kind of a non-stop process. Hospitals, I think, followed actually the health plans and started implementing central medical records at the very in the first decade of 2000. And in 2004, the Clalit Health Plan, which, as I mentioned, is the largest still, it covers about 50% of the population, implemented a web-based health information exchange system, which basically was the prototype and was adopted by the ministry along with everybody else as the prototype for the National Health Information Exchange. And by the way, this is not something that just evolved. This was actually a decision. In 2010, we had a very big national meeting of all of the stakeholders, and this was the question. The question was discussed: do we want a national central electronic medical record, or do we want a decentralized system with a health information exchange? And essentially, the decision made by consensus was to have a national health information exchange system and not to do a central national electronic medical record. So it was the first national HIE was implemented in 2015, and an upgraded exchange is now in its final stages of national implementation. So from an organizational perspective, the Ministry of Health began to exercise proactive leadership and coordination in the eHealth system in about 2004. And initially, they had a joint department of digital health and computerization that dealt with computerization of the ministry as well as projects for the broader system. And in 2011, this department began to focus more on promoting eHealth innovation nationally. And in 2018, a dedicated department for digital health was created in the Ministry of Health, which is now very, very important and very central to the way things are to, I would say, eHealth governance in Israel at the national level. This is what the organizational structure looks like, and I apologize for the fact that the letters are so small, but you can see this also in the report. And you see that, you have the Minister of Health at the top, and you have the Director General of the Ministry of Health, and then you have the various divisions and departments, and interestingly enough, the digital health division department is in the division of regulation, IT, and digital health, along with some very other interesting, not necessarily clearly related issues. For example, in the same department, you have the ombudsman that gets complaints from the citizen population, and then has to deal with the healthcare providers, both hospitals and health plans, in solving problems. And also the supervision of the health plans and supplementary insurance is also in this department. But here, that's where their digital health department is. And if we look at the digital health department in terms of where it is now and what it's doing now, basically it's operating in three major areas: healthcare services, information and infrastructure projects, and research and development. So in healthcare services, for example, they have what they call challenge tenders, in which they basically, in order to encourage and facilitate the development of pilots in areas where they want to promote more activity, they also then can put out tenders and provide grants. And they're also working on some other areas, such as they're trying to create a national system for online appointments and pre-authorizations, which will enable patients to get that service nationally without being limited to their health plan. The information infrastructure projects that they are currently strongly promoting are the new health information exchange system, cloud computing, which has taken a long time before Israel was willing to go in that direction. They're also pushing FHIR very hard now. And they also have a project dealing with terminology. And what they're trying to do now is to implement not ICD-10, but IC-11. Israel did not implement ICD-10, and SNOMED. And in research and development, they have actually developed a big data lake, which is called TIMNA. And they are, which creates basically anonymized data from all of the hospitals and the health plans. And they are trying very hard to encourage healthcare researchers to use this data lake for research. And I think if you read in the newspaper about the fact that when Israel went out to buy its first vaccinations from Pfizer, they made a deal with Pfizer about giving it access to data. I think that this was part of this whole research and development project. So the Department of Digital Health, and I think it's important just to look at its functions from a governance point of view. What they are responsible for is the development and updating of the National Digital Health Strategy in coordination with all of the stakeholders, providing incentives for upscaling digital solutions through tenders for projects and grants, enacting enabling regulation to remove barriers and reduce risks, and developing and implementing and operating the national infrastructure, such as the health information exchange and things I've mentioned already. I won't repeat it. Encouraging partnership between healthcare organizations and industry, encouraging and supporting research and development, promoting and assuring system learning based on ongoing exchange of knowledge and experience among all stakeholders, and assuring public transparency. And I think what's really important to stress here, and by the way, the person who is my partner in crime here in developing both this presentation and in writing the report that you will have access to, is the head of the digital the digital health department in the Ministry of Health. So we work together. So I wanted to make sure that I was giving you accurate information, and she has been a very good partner. And one of the things that she stressed to me is that basically the Department of Digital Health fulfills its functions by working together with the other Ministry of Health departments and other major stakeholders, and by essentially not trying to impose on top, but to basically bring everybody along and get everybody on the same page. So if you look at the overview of the stakeholders, the national layer, the Office of the Prime Minister actually in Israel has taken a very active role in promoting digital health. Obviously the Ministry of Health. Then there's the Israel Innovation Authority, which has been very, very active. And it's not limited to healthcare, but it has a very strong healthcare division. The Ministry of Finance has been very supportive, the Ministry of Economy and Industry likewise, and the Council for Higher Education. So these are all basically stakeholders at the national level. When you look at the one of the things everybody always asks is about citizen representation. And we have citizen representation in national committees and councils, but the main eHealth stakeholders are still the health plans, the hospitals, the Israel Medical Association, other medical and professional associations, the Pharmacy Association, and industry and technology partners, and that's what really drives the system. The health plans, by the way, all have strong citizen representation on their governing bodies and are expected to be citizen advocates. And increasingly, Israel is beginning to do what actually the European Commission has been doing a lot of, and that's to do public consultations. So they do periodic public consultations with the entire ecosystem to encourage broad input. And I've given you an example here, which was the 2020 public consultation on a guide for assessing digital health technologies. If we look at the innovation layer, I think innovation in digital health in Israel is a national commitment, not only to driving it at the national level, but to global leadership. And with multiple players from top government, healthcare providers, tech and industry partners. And it has several key components. There are something like 670 active digital health startups from a variety of digital health segments, half of them at post-product phase. There is, of course, which I've described it, ad nauseam, high-quality community-based healthcare system, which are the health plans, which is offering a unique set of at least 25-year-old, it's actually getting closer to 30, digital databases. And they also serve as beta sites and innovation hubs. There is mature medical device, pharma, and tech industry with global business know-how. And so we have a lot of companies that are pretty advanced in AI, cybersecurity, and additional computer sciences and life science skills. And there's extensive support from venture capital investors, NGOs, and the government in digital health innovation in Israel. And this is sort of kind of like, I got this off of one of the documents I read, but I thought it was helpful to be illustrated. This is sort of like a picture of Israel's digital health ecosystem. So you see the digital health companies, the healthcare providers, then you have the medical devices, pharma, and these are sort of the layers of the ecosystem. There are also some organizations that have been very, very active in promoting innovation in Israel. One of them is HealthIL, which is a nonprofit digital health innovation ecosystem. And as you see, it's a joint venture of all of the national stakeholders. And then you have another one, which is a very interesting network, the 8400, the Health Network, which is basically a cross-sector leaders network, in which it's a leadership program comprised of leaders from business, government, academia, NGOs, healthcare payers, and providers who kind of all come together to talk together, work together, and do collaborations. So those are two organizations that have been very active in Israel in promoting innovation. And I'm not going to explain this slide. I just threw it in because I think it's interesting looking. But it sort of gives you an overall picture of the digital healthcare landscape in Israel. When we look at the main governance aspects, so planning and strategizing, as Tino mentioned, at the national level, this process is led by the Digital Health Department and the Ministry of Health, but it's guided by the National Counselor for Digital Health and Innovation in Healthcare Services, and in collaboration with all of the other stakeholders that we mentioned before. So that's at the national level. At the health plan and hospital level, planning and strategizing are led by internal steering committees that take into account local as well as national priorities. And basically, there's interaction and cross-fertilization between these two levels because there usually also are representatives of health plans and hospital people sitting on the National Council for Digital Health and Innovation. But to give you a little bit more information about the National Council for Digital Health and Innovation, it's basically a multidisciplinary 45-member policy and strategy advisory board to the Ministry of Health. And it's comprised of representatives of all of the healthcare system stakeholders. And I think one of the things that is perhaps important to mention is that the people who are members, the 45 members of this National Council for Digital Health and Innovation, are not appointed by their organizations. They are actually appointed by the ministry, and they are chosen because of their experience and knowledge in the field of digital health and innovation. So you have some of the really most senior and experienced people who actually are no longer attached to a particular organization that sit on this advisory board. As far as financing of eHealth investments is concerned, the majority of eHealth financing is at the health plan and hospital level. Both all of the health plans and the hospitals have yearly budgets for both development and maintenance of their eHealth systems. Investment at the national level is government financed, and investment in eHealth innovation comes from a number of sources, including the government, the Israel Innovation Authority, venture capital, multinational corporations, and international R&D, such as European Research Framework, and Israel has been a very, very active participant in Horizon 2020, and I presume will also be in Horizon Europe, and also gets R&D funds from other places. In terms of interoperability, and I basically have already said this, but I'll just kind of say it again. What really, the Ministry of Health sort of sets national interoperability standards such as coding systems for diagnoses and procedures and communication and cloud computing. But the National Health Information Exchange has been a major instrument for defining and enforcing interoperability because all of the participants must conform to the interoperability standards of the exchange. And that's on a national basis, and that's been very important. I mean, everybody had to do a lot of work at the health plan level and at the hospital level to restructure their databases to conform with interoperability standards of the exchange. And in addition, there are also local efforts between selected health plans and hospitals to improve and expand data sharing and communication at that level for purposes really of integrated care. I think the approach to governance for developing new building blocks, and some of those you saw on the slides that I showed you for the digital health department, is really coordinated dialogue, collaboration, and providing incentives. And the approach has been increasingly citizen-centered at all three levels. Essentially, when we build new programs and new technologies and new systems, they are basically the goal, I think, at all of the levels is to meet citizen need and eliminate unnecessary bureaucratic hurdles in accessing healthcare services. And certainly Israel views existing and emerging digital technologies as a very, very important enabler for this purpose. Because this is Tino's fault, this slide, because he did it for Catalonia. And I'm not going to go through this because I said everything that's on this slide, but this is something that you can go back to and look at if you want to just get an overview of who the key actors are for the major kind of governance activities. And I said it, so I'm not going to repeat it. Okay, so with all this, if you look at Israel overall, what has been its successes and what could be done better? So Israel has clearly been a leader internationally in the digitalization of all its healthcare systems. This has given Israel a huge data repository, which is basically enabling it to be very move very rapidly in the field of big data analytics, cognitive computing and artificial intelligence. I think it's been a leader in providing citizen access to medical information and provision of virtual services. It's also been a pioneer in telemedicine, and that was really important when we needed to basically enable rapid deployment of new remote care services throughout the COVID pandemic, past and existing. But I would say that there are two areas where Israel needs to do more. One is I think Israel needs to accelerate the use of telehealth and telecare, particularly in the area of remote patient monitoring and video consultations. And even though we saw, I mean, the technology exists. It's not a this is not a matter of technology. This is a matter of willingness on the part of professionals and cultural and organizational barriers. One of the things that we found was that during COVID, we strongly encouraged, for example, video consultations, and many of our doctors preferred to use the telephone and not to do video consultations. And it was a very interesting thing, which we're studying right now to try to understand why that is the case. And so this is one area where I think we could do better. And the other area is we need better integration with social services and exchanging data between the healthcare services and social services. And this must be tackled. So those are two things that I think can be done better. If we look overall, I would think that we can say that Israel is an example of a successful bottom-up decentralized e-health system, which has become over the years increasingly coordinated and integrated at the national level. Competition among the health plan and among hospitals for digital excellence has been a very powerful motivator for ongoing development and innovation. The Ministry of Health, and particularly the Digital Health Department, I think have developed their governance processes very wisely to use and take advantage of what already exists in the best possible way and to build on it and not to replace it. And their approach has been to support, facilitate, and drive rapid acceleration in e-health innovation, digital transformation of the healthcare system, and so on. And they, as I say, they've done this by, I think, encouraging, incentivizing, facilitating rather than imposing. And I think that's kind of an important takeaway.
Thank you very much, Rahel. We have one question in the chat box from Kali Killer. She's asking, when developing citizen-centered e-health, how do you secure wide range of representation of patients and citizens, and who are your main partners?
So as I say, we have citizens sitting on all of the national councils and committees. There are also citizen representations on all of the national councils. But also at the health fund level, one of the things that we do, and I think this is true of all of the health funds, is that we have a lot of forums, citizen-based forums to get citizen input in terms of understanding what citizen preferences are in development of services. And for example, when we developed the portal, we had focus groups with citizens in order to understand what their needs were, what they wanted, and then we did even more of that when we went to develop the mobile application of the to give them access to the portal through the mobile. So the health plans have been very, very active. I mean, first of all, for example, the boards of directors of the health plans usually have a high percentage. I know in Maccabi, it's at least something like 60% of the board of directors are representatives of citizens. Are citizen representatives, not professionals, but actually citizens. So the health plans are very, very citizen directed.
We have the raised hand from Luke and another question in the chat. So maybe Luke, you want to start?
Yeah, very quickly, two questions. Rahel, how have you been or are you governing relationship between eHealth and eGov in Israel? And the second one I didn't hear you so much speaking about is about meaningful use. And basically, you spoke about the development of tools and coding systems, but you didn't mention very much what actually has been done in order to make that happen. Not only making this available, but meaning having structured and meaningful data available for multiple use. So could you elaborate a bit more on that?
As far as eHealth and just generally the e-systems in Israel, I think that because actually eHealth was probably one of the first public sort of care systems to be developed, it's only recently that we're beginning to see cross-fertilization between the digital systems of other aspects of governance a lot together with eHealth. And I think that there's now a lot of dialogue, particularly at the level of the Israel Innovation Authority, and also we have something called the Startup Nation, talking about how they can basically take systems developed for something else and use them in eHealth and vice versa. So there's a lot of that going on, but I would say it's fairly recent, like within the last decade. In the beginning, when they began to develop the eHealth system, it was pretty much in the healthcare area, and not so much related to other digital systems that were being simultaneously developed in other parts of public governance. So sort of that's the answer to the first question. You know, as far as meaningful use is concerned, I don't even know how to really relate to that question. I think what happened was that when the health plans started to develop their electronic medical records, they basically sat down with the medical profession and they basically said, what is it important to know in order to give really good care to patients? So what kind of data needs to be in the system that you can all have access to that will enable you to give the highest optimal care? And we didn't do what like America did. America, after technology was very well on the way and wanted to encourage doctors to use electronic medical records and wanted to provide incentives, created the whole concept of meaningful use to be able to say, I mean, how did that come about? They came about because they basically said, if your electronic medical records meet the criteria for meaningful use, then we will give you money. That wasn't how it developed in Israel. In Israel, and this is, I think, more similar to the way it is in Estonia, the health plans pay the doctors. So basically the health plans, ultimately after they had discussion and dialogue and came to a conclusion with the professionals about what data needs to be there for meaningful use, basically said to the doctors, hey guys, this is the system, this is what you have to document. Now, at the beginning, when we first implemented the electronic medical records, we asked doctors to volunteer. We started with the doctors first, before the other healthcare professionals, and we asked them to volunteer to implement electronic medical records. And basically those first volunteers went through a lot of pain working out the bugs. But once the system was in place, essentially the health plans and their healthcare professional leadership determined together with the professions what was the information that needed to be available in order to give optimum healthcare. And that's how the whole system has evolved. So it's been an evolutionary process, and I don't even know that there's criteria that have been written anywhere which say that an electronic medical record must include X, Y, and Z, but they all do. They all do. So they all have to include diagnoses and symptoms and medications and laboratory results and imaging results. And all of that has to be there, and it's all accessible. And now it has to be accessible and available by anybody taking care of that patient, including the patient himself. So I don't know if that answers your question, Luke, but it wasn't.
Yes, that's fine.
The question was also whether it's accessible in real time. If you store the information in different healthcare providers, how much data is accessible real time? Or is everything accessible real time?
Okay, so for the GP has access to everything. Unless, I mean, basically patients have a right to opt out. You know, we have a central medical record and the patient can say, no, I don't want anybody to have access to anything but his own record. So all of the doctors have their own electronic medical record. And if a patient opts out, he can say, okay, I don't want the doctors to be able to see anybody else's stuff, only his own stuff. I think that there is not a single patient in Israel today that has opted out. At the beginning, when the opt-out option came into being and was advertised, I think that there was like a very small percentage of patients who opted out, and they have since opted in, because I think everybody realizes that the extent to which people have access to all the information enables better care for them. So the GP has access to everything. And then specialists have, and basically they sit down and revise these all of the time, but specialists have access basically to the information they need to have in order to provide the care. So I think that, for example, I don't think that, for example, an ophthalmologist has access to everything that a GP has access to. And certainly, by the way, healthcare professionals that are not physicians have also, you know, there's a whole authorization hierarchy in terms of what information they can access, depending on what their role is. So, for example, nurse case managers who are taking care of chronic patients and are providing case management and acting as integrators of the care for chronic patients, have access to the whole record like GPs. And basically, they asked patients, before they gave the nurse managers the right to do that, they asked the patients if it's okay. So the patient basically has to consent to that.
Question from Kerti.
Yes, thank you. May I ask who is in which body, or who are the ones deciding on the data access?
It depends at what level. For the health information exchange, basically that decision is made by the Ministry of Health. In other words, in terms of the data that's available and is accessible by the health plans, the primary care physicians, and by the hospitals through the health information exchange, that's decided by the Ministry of Health. And by the way, they do that pretty collaboratively with the hospitals and the health plans. In other words, when they want to add new data, they talk about it first before they add it. But basically, it's the Ministry of Health who decides. At the health plan level, each of the health plans has a health division that is responsible for making that decision at the health plan level. And obviously, at the health plan level, there's access to a great deal more data than there is at the health information exchange level.
And if I may continue, I would like to have one more clarification that our colleague Neeme was referring to was about data availability and if data is available in real time. So may I ask about the documentation processes or the ways that the data is put into the system?
Basically, at all of the health plans, there's a central medical record. Everybody's working on the same platform simultaneously. And as the doctor is working, and he puts in, first of all, most things are coded, so they have a lot of drop-down lists to choose from, like, for example, to pick a diagnosis. But I'll give you an example of how it works. I went to a couple of years ago, I went to my family physician. I don't remember what was wrong with me, but he sent me for an x-ray. And in this particular medical center, the doctor, where the doctor was sitting, there was also an x-ray department on the same floor. He basically put in the referral for the X-ray. I walked down the hall and the referral was already in the computer at the X-ray. And I did the X-ray and I walked back to the doctor and he had the X-ray already on his computer. So it's a system that operates in real time because it's a central platform. And so everybody is kind of, the minute they put it in, it's there.
But then my question would be, if you would go to a different doctor, when would the first doctor put in what they saw in this medical image?
He puts it in as soon as he sees the patient,
Right.
he enters it, and anybody else that's on the system and has access to that patient's information, which, by the way, is not a simple thing. In other words, a doctor, in order for a doctor to have access to a patient's information, the patient has to have visited him, I think, within the last 3 to 6 months. Otherwise, and he can then enter his ID number and see information, but he can't do it for any patient. Only patient that is defined in the system as an active patient of his. But let's say if I go to my, I'll give you a live example. I went to my GP. She sent me for tests. Then I went to my cardiologist, and he was able to see everything that my GP put in immediately. But immediately, it's like there's no time lag because they're all working on the same system. So once it's in the system, then whoever has authorized access can access.
So everything is basically centrally stored.
Right. At the health plan level. Now that's not true of the, there might be a lag at the national level in terms of health information exchange, but not a great lag. Because the hospital, I mean, for example, the hospital needs to be able to see the key elements of the patient's record when the patient comes to the hospital. So he has to be able to see what medications he's on. He's able to see what his most recent blood test results are. So I think that I don't know how often they upload to the server for the HIE, but several times a day. So it's not the same as the health plan level, which is really, I mean, instantaneous. But at the health information exchange level, there is also frequent uploading so that the information is current.